So, may I have your attention, the esteemed faculties and delegates? I would like to take a few moments of your time to introduce myself and the distinguished faculty members of this session. A very good afternoon and a warm welcome to all the dignitaries present over here today. I am Rituparna from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. And it is with great pride that Clarinet serves as a digital partner for this online event hosted by the National Neurology Forum, Gujarat chapter. The focus of today's session is clinical approach to critical congenital heart diseases. Now, without wasting any further minute, let's begin today's session, for which I would like to invite Dr. Kunal Ahiya, the Honorable Secretary of NNF Gujarat chapter, to start the event today with his enlightening words and for the further coordination. So that is all you, sir. Please proceed.
Yeah, thank you, Ritu. So today we are continuing with our focus series. So today is the 18th focus series. So one of the fear which we all have while doing our echocardiography that we should not miss any congenital heart disease. So to enlighten us, we have Dr. Mohit Sani with us, and thank you so much, sir, for the continuing support and continuing this focus series for such a long time. I would request Dr. Krunal Shah, EB member of NNF Gujarat, to introduce Dr. Mohit Sani, sir.
Thank you so much, Kunal. Welcome to Svetal ma'am and Kunal here yourself also. And it is my privilege to introduce our own neonatologist from Surat. He's a very well-known and popular figure in field of neonatology, and that too in the bedside echocardiography, the which program is focused. Sir is director at Surat Kids Hospital, editor of the Journal of Neonatology, ex-president of NNF Gujarat, and his keen interest in NRP and bedside echo, everybody knows. And without wasting much time, we'll ask sir to start his session. Thank you so much.
Thank you, Dr. Kunal, and thank you, Dr. Kunal, for for making this possible and for the introduction. So, as we have finished up with the functional issues of the heart, that is the PDA, PPHN, and shock. Now the next step will be, which is a bit more difficult, but that is very important from Indian scenario point of view, is the congenital heart diseases. So whenever we do the functional echo and we see something which is abnormal, it is always important to take the help of pediatric cardiologist in that moment so that we can save the baby. So any time in your life, something will come. Recently, I had an example that there was a baby which was antenatally diagnosed as interrupted IVC. So I was somewhere, and then that reports were not there or something issue was there. So it has been communicated that it was been interrupted. Everybody thought it's interrupted aortic arch. So when the baby came and they called me, I told, if it is interrupted aortic arch and the baby, even though it is still fine, start with the prostaglandin, and then we will review with an echo. So we started with the prostaglandin, but then after some time when the echo was been done, so it was interrupted IVC, which was already diagnosed antenatally. So then we had to stop with the prostaglandin. So the first and foremost message from my side is, any confusions regarding duct dependent lesions, if that is there, it is always safe to start with the prostaglandin, and then you can review later on also. So but today we will start the session with the clinical approach, because whenever we go to do an echo after the clinical examination, we already have the diagnosis there in our mind, differential diagnoses are there in our mind. So now today, in today's session, we will see how clinically we approach those patients, and in many of the times you will be very near to the diagnosis. And then I request all the participants today, if possible, they can just put it in the chat box, and whatever the questions we will be discussing, they can put their comments and answers in that, so that will make it more interactive. So I will share my slides. I don't know, something has happened to my laptop or what. Able to see the screen?
Yes, sir.
Okay. So these things which I put is basically this is an approach that that is what we call as used to call as a Stone Age approach, but that is what we correlate clinically also. That is the one approach that we approach the critical heart disease clinically, and another one is the advanced approach, which is the echo approach or the ultrasonography or all the advanced investigations what we do nowadays. That is this approach. So I would first like to ask the people, which is more reliable, this one or this one, or they augment each other. That means we cannot miss any of these. They both are needed. Anyone wants to put something in the chat box if they can? Both. Yeah, fine. Yeah. So both are needed. That is very important. Yes. And now the next question is, which is more common, acyanotic heart disease or cyanotic heart disease? If anybody can put it in the chat box, which is most common, acyanotic or cyanotic? Acyanotic, yes. So acyanotic heart diseases are more common. Yeah, most of you have answered is correctly. Great. So let's start with one scenario. This is a baby born at 35 weeks. Birth weight is 2.5 kgs. At birth, the baby is tachypnic and cyanotic. At 4 hours, tachypnea and cyanosis increased. So the baby operated F5 to 100% on ventilator. SpO2 increased from 65% to 85% after the ventilation. Like it increased by 20%, but still it is low, and the X-ray has been done. Something has happened to my laptop. Sorry, something is not right with my laptop. Sorry. So this is the X-ray. Anybody wants to comment on this X-ray? What is the X-ray? Okay, so the diagnosis has been written. It is TAPVC. Okay, fine. We will just see how we can approach that, whether it is TAPVC or not. We will see to this. Okay, so as you can see, it is all white out. Why my laptop is not working? Okay, so as you can see, there is a diffuse haziness. So it was being thought that it may be the RDS. So one dose of surfactant was given. Till 6 hours after the surfactant, there was no improvement. So what's next? Options are A, give second dose of surfactant, B, get an echo done and review after 6 hours if the baby is maintaining saturation. So what is your, okay, B, echo. Okay, yeah, fine, because you want to make a diagnosis for that. And second dose of surfactant, already one dose is being given. In bigger babies, to before you give second dose, it has to be evaluated. Okay. So we will come to the scenario again. So now the thing is, which all babies needs to be screened for the congenital heart diseases? So there are two categories of babies. One is the babies who are stable, and one the babies who are sick. Stable babies, as we all know, in most part of the world, there is a SpO2 screening protocol. By virtue of that, SpO2 screening has to be done for all the babies at 24 to 48 hours of birth, whether there is a cyanosis or they are not sick, or whether they are no issues are there. We just go for the SpO2 screening. Then the second category is the sick babies. If their SpO2 is low, they're in shock, distress, you have to rule out CHD if they're sick. So they automatically comes and get screened by this. But stable babies needs to be get screened by the SpO2 screening. So this is all well infants who are on room air within the age of 24 to 48 hours, or less than 24 hours if they are being planned. If you have planned a discharge, if you have planned a discharge less than 24 hours, if you have planned a discharge less than 24 hours, so in those babies needs to get a screening by the pulse ox, and that has to be done on the right hand and on any of the foot, that is preload, preductal and the postductal. When we do the first measurement, we put it in the category of fail if the SpO2 in either hand or foot is less than 90%. Okay, so they qualify for getting an echo done immediately. We tell them that they are passed, that SpO2 is more than 95% in both right hand and the foot, or the difference between the right hand and the foot SpO2 is less than 3%. But this yellow zone is something we need to take care of, that if the SpO2 is in between 90 to 94% in any of the right hand or the foot, or the difference between the right hand and the foot, that is preductal and postductal, is more than 3%, then we need to reassess them after 1 hour. If they fall in the category of fail, they immediately go for an echo. If they pass, they are passed. But still in the second measurement, they are in the yellow box. Then again, they have to be reassessed at 1 hour. Either they will fail or pass. If they are on the third measurement, again, if they are in the yellow box, in this yellow category, then that has to be assessed by an echo. So this is how we do the SpO2 screening of the babies, which are well babies, which are stable. Okay, and most of our diagnoses nowadays are made antenatally. That is very important. And recently, at the start of the lecture of this session, I gave an example that recently I have come through, that even with antenatal established diagnosis, there can be misunderstandings. And if those misunderstandings are there, you have to take a path which is less lethal for the baby. Okay. Now, we discuss another scenario. I will come to those scenarios that I have discussed initially. So this is a baby born to 30 years old primary with rupture of membranes 10 hours prior to the delivery. A male baby delivered at 2.85 kgs, cried immediately after birth, born by normal general delivery. Discharged second day to home. Checkup. The baby came for a checkup on day 4th of life, and this baby is sitting in your OPD. Many a times you must have gone through this, came across the babies like this. That baby at day 4 sitting in your OPD, not feeding well, lethargic, less urine output. On examination, the baby is mottled, poor pulses, cyanosed, and is gasping. What you will do? That is, A, you start the resuscitation, you look for the cause, and send the baby to the higher center without any intervention. What will be your approach? Anybody can write in the chat box. So people are writing A, B, 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 look for the cause. So there are mixed responses, but approach will be to start with the resuscitation first, because the message through this slide I want to give is whatever may be the cause of deterioration of the baby, respiratory, metabolic, or cardiac, our first approach is for A, B, and C. So that is our resuscitation, irrespective of any cause. Once you resuscitate the baby well, then you look for the cause along with that. So that is important. So resuscitation is first. So then, what are all your differentials for this scenario that I have just discussed? What are all the differentials? Anybody can write 1122. Sepsis, yes. Very common, very important. Anything else along with sepsis? Anyone wants to write another any other differentials for this baby? CHD, yes. Yeah. So the differentials: sepsis, cardiac, hypoglycemia, may add seizures or IVH, or can be a metabolic. So these are the most common differentials that we can think about in this scenario. So our diagnostic approach is first, that is very important, is the history, then the vitals, third thing is the examination, and then fourth one is the investigations. So we will talk about all this. In few of them in detail, in few of them we will quickly discuss about that. So in history, when we talk about your antenatal history, antenatal reports are very important, and you should go through them very well. Otherwise, the confusion will be created, as I've just given you the example that happened to us 3 or 4 days back only. Perinatal history, feeding history, activity of the baby, urine output, abnormal movements. These are all things which rule out of your differential causes that we have just discussed. Then comes the vitals. So in the vitals, heart rate, SpO2, capillary refill time, body temperature, blood pressures, pulses, perfusion index, and blood sugars. These are the few things that we will have to do, and we have to do it very appropriately. Like when I talk about heart rate, you just don't ignore the heart rate, the numbers. One thing is, if you babies are sick, then you tend to get this heart rate on the monitor by chest leads, not by the SpO2 monitor. That are more appropriate. If the baby is tachycardic or bradycardic, you should evaluate the babies accordingly. SpO2 is not just only one reading of SpO2. You have to make sure that what you are reading, reporting, or what you are seeing is preductal or postductal, and what is there any difference between preductal and postductal. Capillary refill time has to be done at a place which is nearer to the heart, so that is your sternal and not the peripheries, because the peripheries can be cold, because it may be because of the temperature, or and they are away from the heart. The CFT what you get in the peripheral areas is not as accurate as compared to the areas which are nearer to the heart. Body temperature is one of the vitals, and that is very important to rule out. Even you can, now you have the guidelines to make the diagnosis of early septic shock. You can make out with the just by recording the body temperature. Blood pressures, when we talk about the blood pressures, it is not only that one blood pressure or NIBP or IBP. When you do NIBPs, then you have to do it with the appropriate cuff, and always try to compare upper limb and lower limb blood pressures. And whenever we talk about upper limb and lower limb blood pressures, it is always with respect to the systolic blood pressures and not the mean blood pressures. That is very important. Whenever we talk about pulses, again, upper limb and lower limb pulses, brachial in the newborn and the femoral pulses. Perfusion index is something you can very well take care of, take the services of perfusion index, because that is very well there in front of you if you are doing SpO2 monitoring, and the blood sugars. Never forget that. Okay. So the normal range everybody knows regarding the heart rate. Yes. So So it can be done by various methods, auscultation method, ECGs, lead, and this thing. So I've already told you that best method will be the ECG leads. That has to be done ideally. And then these are the bradycardia. If it is less than 60 per minute persistent, it is bad. And tachycardia, then you have to look for the tracing, if a baby is with the chest leads, how the waves are been looking at. Okay. So as I have told you that ECG leads are more reliable. So and the other concerns you have to look, but so just by noting the heart rate, it gives you a large amount of information. Yeah. So a good question. Why bradycardia in two groups? That is very important. Good. So nice. I think the people who have been attending, they are well awake and their approach is good. So it is very appropriate question that why the bradycardia is being, I have put it in two groups. See, one, by definition in newborns, if your heart rate is less than 100, by definition it is a bradycardia. But then the question comes 60 and 100. And if you go through the NRPs, previous NRPs and the latest NRPs algorithm, the heart rate has been changed from 60 to 100 and the actions has been taken like that. And if you ask me that clinically when we manage the babies, so what is the heart rate at which I will surely take an action? So what we have found is, what the people have found is, if your heart rate is less than 60 in the term newborns, that is detrimental if it persists. But if it's between 60 to 100 and your perfusions urine output has been maintained, then it will not be effective to your hemodynamics. So that's why you should be cautious if your heart rate starts going below 100, but definitely you should act immediately if your heart rate is less than 60. So that's why your bradycardia is being divided into two categories. One is take the action immediately, and one on which you should be you're aware of the situation, monitor the babies well, but you can delay your actions. So that's why it has been divided into two groups. Very nice question. So these are the few differentials I have just written. There can be many, but my main concern is, like, I don't want to discuss arrhythmias and everything in this, but this is to, when you put the chest lead, just don't see the numbers, make sense out of it, and always look for the tracings to look for the arrhythmic patterns. That is very important. Then we come for the SpO2 monitor. We always talk about preductal and postductal. So everybody must be knowing the preductal is before the duct and the postductal is after the duct. So this is the diagram you are seeing is the arch of aorta. This is ascending aorta. These are the transverse aorta with 3 branches, and this is a descending aorta. When the descending aorta, after the third branch, it starts, this is the isthmus of aorta. Isthmus of aorta is a place from where the duct starts and it goes up and joins the pulmonary artery. So this is the most common site for the coarctation of aorta. So anything which is before this, before the duct, is preductal, and after this is the postductal. So this is how we do the pre and postductal saturations. So your left hand is also, I just wanted to show you that the left hand is also a preductal. In 96% of the population in the world, your left hand is also preductal. Only in 4%, this thing, the duct may starts from here, and your third branch, left subclavian, may be after the duct. So in 4%, your left hand is postductal. But in 96% of the population, your left hand is also preductal. So in CHD screening, as I have already told you, the preductal and postductal saturations we see, and the difference to be very stringent is 3%. But many places we also take, if the difference is more than 5%, it is significant, preductal and postductal. So there comes the question of hyperoxia test, because that is, now we will be discussing the approach for the critical congenital heart diseases. And more common are acyanotic, but critical ones are the cyanotic ones. So we will discuss those, the approach, that how we can approach these congenital heart diseases without getting an echo done. So for the first, when you are getting preductal saturation is low or your differences is more, preductal and postductal, we do one test which is known as hyperoxia test. So what we do in hyperoxia test is we give 100% of oxygen for 5 to 10 minutes, and then we get ABG in the right hand, get RABG in the right foot, get ABG in the left hand, get SpO2 in the right hand. What is your answer? A, B, C, or D? A. Okay, so one person has written answer A, one has written B. So the answer is you give 100% oxygen and then you have to look for in the right hand. So all other things, right foot, left hand goes away. So then the two options left in front of you, one is, these are the two options of right hand. Okay, these two are gone. So now to see what is the difference between this. In one we are doing ABG in the right hand, in one we are doing the SpO2 in right hand. So now how you will what will be your answer? A. Most of you people have written A. Yes, it has to be a blood gas because we want to look at PaO2s, not SpO2s. In real hyperoxia test, if you give 100% oxygen for 5 to 10 minutes, you need to see the PaO2. So need to get the ABG done in the right hand and not the SpO2. Okay, so this is your answer is A, which has been rightly written by many of you. So this is the interpretation of the hyperoxia. PaO2 is more than 150. It is mostly the pulmonary pathology. If the PaO2 is between 100 to 150, it can be congenital heart disease or PPHN. Then we used to do a hyperventilation test. In hyperventilation test, now we avoid that. It's an absolute test because with CO2 washout, everybody knows there is a white matter injury in the brain, so we don't do that. But if your PO2s in the right hand are less than 100, then most likely it is congenital heart disease. Sometimes it can be very severe PPHN, but most likely it is congenital heart disease. So that's how hyperoxia test will give us an idea whether we are dealing with the cyanotic congenital heart disease or with the PPHN. Okay. In vitals, I have already explained you all these things. I just want to press on proper size cuff covering 2/3 of the limbs and do it in the upper limb and lower limb, pulses in upper limb and lower limb. And this perfusion index is this, perfusion index is this pulsatile bar that you see by the side of SpO2. Okay. And it gives you the information of the trend. The single reading is not very useful. It gives you the information of the trend. The normal range should be more than 0.6. Okay. If suppose you're at one time, like at 3 p.m., the tissue perfusion index was 0.8 to 0.9, and then persistently it is coming down and it has come down to 0.6 or 0.5. So that gives you an idea that over this period of time, the perfusion of the tissues in this baby has been affected. So you should be well aware and careful with that. So for which we should initiate the screening. Okay. So one is stable babies, as we have already discussed. So evaluate the newborn or infant for CHD if there is a persistent respiratory distress, persistent central cyanosis, murmur. Murmur is very vague. It is not the indication, but in combination with the other things, it can be indication. And then for the well babies, if those babies have failed the SpO2 screening. So those are the babies you need to screen. Okay. So let's talk about one scenario. Born to 22 years old gravida 2 mother, had a fetal distress. Baby male is being delivered, 3.1 kg, cried immediately. By LSCS, discharged to home. Third day, regular checkup, 5th day of life. Active. The baby is active, but having a central cyanosis in the lip. So lips are blue. The baby is fine, weight is good. Okay. On 5th day, it has been noticed that baby is blue in the lip. So how to approach? First, as I discussed, history you have to take, detailed history, and then you look for the vitals. In vitals, you see heart rate is 126, which is normal. SpO2, pre-ductal is 83%, post-ductal is 84%. So pre and post both are low and they are less than 90%. RR is 38 per minute, which is normal. Temperature 36.5 degrees Celsius is normal. CFT less than 3 seconds is normal. Pulses in all the four limbs are well felt. NIBP 48 by 40, upper limb and lower limb, almost the same. Pulsatility index 0.9, RBS 108. So out of all these vitals, which is abnormal? Out of all the vitals, which vital is abnormal? Anybody can write on the chat box. SpO2, SpO2, yes, you are right. So out of all, everything else is being fine. The only thing which is abnormal is SpO2. And there is no murmur in this baby. So what action we took? We started with the O2. Okay. When the oxygen was being started, all other vitals remained the same. The SpO2, which was 83 and 84, is now increased to 88 to 89. So even after on starting with the oxygen, it is still less than 90 in both preductal and postductal. So what can be your dice? So these are history-wise, nothing was specific. Okay. Vitals-wise, all we could find was that the SpO2 is low, no murmur. Action we took, we started with the oxygen. Still the oxygen SpO2 is low. So what can be your differentials? Anybody? Clinical differentials for this baby? VSD. Why the VSD would have SpO2 so low? VSD is what kind of mixing lesion? So that means the VSD is not the primary, Okay, duct dependent lesion. TOF, okay, yes. It can be tetralogy of Fallot, yes. So we'll just see. Great. So first thing I want to make is you make a broad classification, because when we approach these babies, we have to classify whether these babies are respiratory or heart. So differential diagnosis will come down, but broadly what we need is, as you have already told with your diagnosis, this is mostly a cardiac issue. So we know that this baby is having cardiac issue. What kind of cardiac issue we will discuss. So the first thing, as I told you, we need to differentiate whether it is respiratory issue or whether it is a cardiac issue. If in the respiratory issues, by the respiration, in respiratory group, if baby is sick because of respiratory issues, the baby will be in distress and tachypnic. In cardiac, it will be comfortable. So our baby was comfortable. Then is cyanosis improve with the crying. Okay. And cyanosis worsens with the crying in cardiac babies. In respiratory issues, if there is a pneumonia or any issues with the respiratory tract or airway, then you may have the rhonchi or crackles. You may or may not have the murmur. So murmur is not very specific. So one thing we would put a stress on is one, my laptop is not working good. Tachypnea and cyanosis. These are the two things. Then comes the X-ray chest. So X-ray chest, lung parenchyma you have to see, and the shape of the heart. But I would say in neonatology, the shape of the heart for particular diseases does not become obvious at the birth. It takes some time, few weeks or month, to be obvious with a particular shape, like egg on end appearance, figure of 8, snowman. These kind of figures, when we discuss in the X-ray chest of the heart, it takes some time to develop. It is not there seen at the time of the birth in neonatal period. Okay. So what we see is mainly, we will discuss that later also, whether the pulmonary perfusion of the lung is increased or decreased, pulmonary perfusion of the lung. And then we look for the cardiac size. And then in the end, we look for the cardiac shape. And the third thing, first thing is clinical assessment of the respiratory system. Second thing is X-ray chest. Third thing is the ECG. These are the three things which help us in making the diagnosis, and that we will discuss that how we can make the diagnosis of a particular case by these three things. So we come down to our scenario. So X-ray chest is being done. These are the chest leads. Echo has been called for because clinically we knew that it is an cardiac disease. Still the echo is not done. So till the echo arrives, we will just assess whether what kind of cardiac disease it is. So now the first thing is X-ray. And somebody can comment on the X-ray. What is the X-ray and how is the X-ray? Okay. Narrow pedicle, oligemic lung fields. Okay. Okay, fine. So I won't say this is a narrow pedicle, but one is first we have to look for in the X-ray. I told you whether it is oligemic or hyperemic, whether the pulmonary circulation is increased or decreased, and then we look for the size of the cardiac shadow. Okay, and then we look for the ECG. Okay, and then we will discuss how to approach that. You are right. Yes. So as I told you in the X-ray, first we will look for whether the pulmonary blood flow has increased, it has decreased, or it is normal. Okay. In our case, it seems to be a normal. It is not oligemic. In your this thing, because on online, this is an issue. In actual perfusion of the X-rays is very difficult to make out. So it is normal. Okay. Then we look for the cardiac sellout. Whether the heart size is large, small, it is normal. First, we see whether the pulmonary congestion is there. Pulmonary circulation is increased or decreased, or it is normal. Second, we look for the cardiac sellout size. It is large, small, or normal. And then we put the ECG. And in the ECG, we need to see whether it is left axis deviation, right axis deviation, or normal. So the only thing you need to learn, especially in the newborn ECG, where one is arrhythmias, yes, but the basic thing you should learn is whether how to identify it is right axis deviation or the left axis deviation. So let's look at our case. When we looked for in the vitals and clinical scenario, okay, we narrow down to it is cyanotic congenital heart disease. Then we looked at the X-ray. In the X-ray, what we looked at, the pulmonary blood flow, it was normal. The cardiac sellout was normal. This is our X-ray. The cardiac sellout size is normal. Pulmonary blood flow is normal. Then we did an ECG. In that ECG, there was no right ventricle hypertrophy, no left ventricle hypertrophy. So there was no right axis deviation, or it was a normal, right, predominantly in the newborns, it is right-sided predominant axis deviation. Axis is on the right side, but it is not like something what you get in RVH. Okay, so now I can bring down my diagnosis differentials to DTGA. Okay, so in DTGA, in the initial part, you will not get the typical picture of. So this was the echo. I will show you that initially in what you get the shape of the heart in DTGA. Can anybody write in the comment box what is the typical shape? Oh yes, agon end, boot shape rod. So these agon end appearance, boot shape heart, I will show you those also. That you do not see in the neonatal period very commonly. That happens in the infancy when these things are being missed at birth, and later on after a few weeks when you look at those babies, only then you get this kind of appearances. So for the time being, in my case, the diagnosis is DTGA because clinically it is cyanotic. X-ray And ECG, with that, I've ruled out that. I will give you another example, and then it will be more clear to you people. So this was the echo of that baby. The parasternal long axis view. In this, you can see this is a vessel which comes out of LV, divides into two. So that is your pulmonary artery. And just above that, you see the aorta. So these are transposed vessels. So this view we also call as the double barrel view. So this is your DTGA. Very typical echo video of DTGA. So now you see, you have the normal blood flow, normal cardiac cell out, normal ECG. It is TGA, but later on, it becomes egg on end appearance. It takes time. Increased blood flow, small heart size, ECG RV types, is TAPVC, but snowman appearance will take time to appear, this kind of x-rays. In newborn, it is not. So you just have to go with whether it is oligemic, high blood flow to the pulmonary vessels, low flow to the pulmonary vessels, small heart size, and then you look for the ECG. So normal heart cell out, large heart cell out. Normal heart cell out, you do an ECG. If it is right ventricle, RVH type, it may be TOF. LVH type, it can be tricuspid atresia. Large heart cell out, LVH type is pulmonary atresia, RBB pattern Epstein shape. So these boot shape heart and everything, as I discussed, will be in the later half of the life. So which are the common cardiac diseases in which you see increased pulmonary vasculature in the X-ray? X-ray will be more white. DTGA, TAPVC, secondary PAPHN, truncus arteriosus. Now in our case, that increased pulmonary circulation was not happening initially. It is because in the initial time, it takes time for that whiteness to appear. Okay. So that is very important. So it can be normal or it can be increased. But with the decreased pulmonary vasculature, the X-ray chest will be black. The common ones are TOF, Epstein anomaly, pulmonary, anything which is causing obstruction to the blood flow to the lungs. And then you go with the timings of the presentation. The ones that present initially in first half will have duct-dependent lesions of the left and right side when the PDA gets closed. In second week, you get coarctation of aorta, large VSD, and these will be coarctation and VSD, large VSD, and TOFs may present in the 3rd or 4 weeks of life also. Yeah, flask-shaped heart is basically for the pericardial effusion. So let's see. In our case, 38 weeks, 3.5 kg, tachypnea and cyanosis. SpO2 in right hand 84% and right foot is 74%. This is upper limb blood pressure, lower limb blood pressure, 4950. Pulses all the limbs are well felt, and perfusion index is okay. So now we need to differentiate whether it is respiratory and cyanotic. So tachypnea on day 3rd and cyanosis, SpO2 pre and post-ductal differences there, blood pressures are the same. So now see what happens. It worsens with crying. When you give oxygen by prongs, 2 liters per minute, okay, ventilated, ABG in the right hand after 10 minutes, PO2 is 80, CFT 3 seconds. So that means it fails hyperoxia test. You have given 5 to 10 minutes, 100% oxygen, and then you did an ABG in the right hand, PO2 is 80, less than 100. So it seems to hyperoxia test is failed. There is a pre and post ductal saturation. So that means it fails hyperoxia test. Perfusion is good. So that seems to be a cyanotic congenital heart disease. Okay. Now the next thing is, if it is cyanotic congenital heart disease, whether it is right-sided obstructive lesion or not. It seems to be because the lesions which are right-sided and duct dependent, they first present with the cyanosis, and lesions of the left side obstructive lesions which are duct dependent left-sided lesions, When they present after initial closing of the duct, they present in shock. So this baby seems to be cardiac and it presents, fails hypoxia test, and it seems to present with a cyanosis first. So that seems to be a right-sided obstructive lesion. When we see in the X-ray, increased pulmonary blood flow, cardiac sellout is large. Cardiac sellout is large, blood flow is increased. So that means either it is a DTJ with large mixing connections, TAPVC, or PPHM is secondary left to right. So, but it fails hyperoxia test. It was less than 80, so that mostly rules out PPHN. These are the two differentials of cyanotic heart disease which we shortlisted after clinical approach and by the X-ray chest. Then we go for ECG. In ECG, what we see is RA-RV is dilated, so right axis deviation. So if it is a right axis deviation, that rules out your DTGA. So clinically, we shortlisted cyanotic congenital heart diseases, severe PPHN, and it was duct or not duct dependent lesion that we have ruled out. In X-ray chest, when we saw, so after this clinical scenario, we had a diagnosis of DTGA, TAPVC, TOF, pulmonary stenosis, because the duct dependent lesions was there in our list, and then severe PPHN. Then on X-ray chest, when we did, we saw there is an increased pulmonary blood flow and large cardiac sellout. So we came down to two differential diagnoses of DTG and TAPVC. When we did an ECG, it was right-sided predominance, right axis deviation. DTJ was ruled out, so we had now in the end left with the TAPVC. So that was a case of TAPVC. So whenever we have, whenever we suspect duct dependent lesions, okay, the first thing is we have to differentiate whether the congenital heart disease is cyanotic or acyanotic. It is acyanotic, then the differentials will be different. It is cyanotic, then we have to look for duct dependent or duct independent. Duct independent, they will not be very sick. Duct dependent circulations are two: systemic circulation and pulmonary circulation. As I have discussed with you, the duct dependent pulmonary circulations, when they present with the closing of the duct, they present with respiratory distress and cyanosis. And systemic circulation, which is duct dependent, when it presents primarily with the shock. Okay, so always have a low threshold to start with the prostaglandins. So this is our first case, what we discussed. And we were thinking of giving echo and doing an echo or giving second dose of surfactant. Everybody told that to do an echo. When the echo was been done, it was obstructed TAVC. That is what we discussed. So it is good that we didn't give the second dose of surfactant. And then for TAPVC, obstructed TAPVC, nothing works. The only thing is you have to rush these babies to the surgery. Okay. So that finishes my clinical approach, that how we will approach a critical cyanotic or cyanotic heart disease by just clinical history, vitals, X-ray chest, and ECG. And then if you have not subscribed, you can subscribe to our NF Echo Neonatal Echo channel, YouTube channel, and follow us on this page, Insta page. It will give you a lot of small videos are uploaded there. There is a teaching videos that will give you insight that how the echo views and all the. Today only I've uploaded a very interesting case. You please subscribe to the channel and please watch that. It is 1 in 1 lakh. It happens in 1 in 1 lakh babies. Very rare case, very interesting one. So it just gives you some few insights. So you please see that. And if you want to have more information about that, you can mail us on nfecho2505@gmail.com. So I will stop my presentation here. And if there are any questions, I'm happy to answer that. Thank you very much.
Thank you so much, sir. It was a wonderful presentation, and we almost take care that you must not miss the basics and looking for congenital heart disease. We sometimes face those kind of cases also. So you should be very vigilant about that. If there are any questions, anybody can ask. Even if they have any questions, they can directly unmute themselves and ask also. We'll wait for a minute. I think there are no questions, sir. So thank you so much. Thank you, sir, for the wonderful as usual. It is always pleasure hearing you. So thank you so much. Thank you, Krunal, for wonderfully moderating the session. Thank you, ClearNet, for the wonderful seamless experience. Thank you, all the delegates. Ritu.
Thank you very much, dear doctors, for sharing such valuable insights. And I hope you had a seamless experience. So, with all your permission, we are signing off for today and looking forward to host you again soon in another interactive session in the near future, sir. Till then, so safe and healthy, and wish you all a very happy Navratri. Goodbye, everyone.
Bye.
Bye.
Thank you. Goodbye.